So what I'll do, we'll continue this discussion, and I will highlight some of the main results about the study, and basically discuss the derivation validation of this respiratory depression risk prediction tool. That was sort of the main outcome of the study. Those are my disclosures. Very good. So this is basically a strobe diagram detailing patient movement disposition throughout the trial. And it basically, just the way the study was designed, it includes, because you'll see this later, full data set, FAS, as well as a modified data set. And basically the full data set included patients with potential respiratory depression episodes, and then the modified one was basically the difference between the full data set and patients who actually received opioids and started monitoring. So you can see, if you look at the study flow diagram with all the exclusions, over time, we basically ended up with about 1335 patients, all the way down to, with 1 month follow-up, about 1282 is the number of patients who actually completed the study, with about 1495 enrolled originally. You already saw the top part, but basically those were the definitions that we used, that were adjudicated. And based on all of the evidence that's out there, we came up with total of 46 potential predictors. And we excluded certain predictors that really didn't make sense at low prevalence, where sort of there was a collinearity with sort of some of the existing outcomes as well. And we basically looked at all of these, and I'll show you something in more detail in a second, to basically come up with this Prodigy risk score using all of the significant predictors, using multivariate risk prediction model. So this is a busy slide, but what I want you to look at is basically, so looking at the 46 original potential predictors, looking at the literature, what's out there, what we know, we ended up using 31 of them, and that's so the green check is next to it, in our models, which included, age, gender, BMI, smoking status, some comorbid conditions like hypertension and diabetes, and so on. And some of the others were excluded for different reasons, listed low prevalence or correlation, things like that. So the 31 that are highlighted on the top of the table is what we ended up using in this model, the multivariate analysis out of 46. So this is a busy slide, but it basically gives you an overview of patient characteristics. As was already mentioned, patients came from the US, Europe, Asia. There were some significant differences. If you look at sort of different countries, in terms of age, in terms of BMI in the United States, obviously there were more patients with BMI over 35, for example. Looking at smoking status, looking at ASA, physical status, for example, ASA's 3, more patients came from the U.S. than other countries. So just important to realize that, the cohorts were not exactly identical, looking at different regions. Also interesting, if you look at opioid demographics, when it says opioid naive patients, only the U.S. had the least numbers, 71.7% versus, say, Asia, which vast majority of patients were opioid naive at the time of the study. So there are some, interesting differences between these patient cohorts. So then we basically created this adjudication process, as was already mentioned. It basically shows you, if you go from all the way down, from the full data set, you're looking at respiratory depression episodes, which basically we identified 655 out of 1495, which was the original data set of monitored patients, and that came out to about 44%, which had at least one respiratory depression episode. And then this number, 655 includes 614 patients who received opioids and started continuous monitoring, which basically comes out to 46% of this modified data set patients are actually getting opioids. And that's a significant finding. It's certainly higher than what's been reported in the past, and it certainly, by any means, is a very significant finding. So that's sort of the essence of this diagram to show you these two numbers. Univariate predictors of respiratory depression, I'm not going to spend much time on it, but the ones that we were able to identify were age, gender, BMI, certain cardiac disorders. Again, you remember, this is a univariate analysis. And certain other comorbidities such as diabetes, kidney failure, asthma, and opioid status. And then we basically ran a multivariate analysis, and this is sort of the essence of the results based on our multivariate analysis of respiratory depression, which allows us to come up with the Prodigy risk score. And so the most important, the factors that we identified, the important factors, patient factors, and again, the reference here, so if you look at the clinical characteristics, the reference age less than 60, and then clearly you can see that risk goes up with age. And that was by far the most significant predictor. And then you get into gender. So then you see on the right, you see points. So we're just talking about the top. So each were assigned sort of a weighted number of points. So you can go from, I guess according to this model, from 0 to 39, which is the highest number of points that you can get. And gender was assigned 8 points, and you have whether you're opioid naive or not, sleep disorders including obstructive sleep apnea and chronic heart failure. So those are the factors identified by this model using multivariate analysis, and each was assigned a certain number of points based on weighting that we did to come up with the model. Then on the bottom here, we basically separated risk scores into 3 categories: low risk, intermediate risk, and high risk. And that was based on point values. So if you're less than 8 points, you're in the low risk category, intermediate risk between 8 and 15, and less than 15, and then greater than or equal than 15, you would be considered high risk. We basically ran sensitivity specificity analysis. But what's interesting is if you look on the very bottom, when you have odds ratios, and it basically IL, HL, HI, basically IL is compares odds ratios of intermediate to low risk. HL compares risk of high to low risk, odds ratios high to low risk. And you can see that the difference, if you high versus low risk, the odds ratio is 6 times. So you're 6 times as likely to have a respiratory event as defined by the study's methodology. And then high compared to intermediate, again, 2.6 times more likely to have an event. So this is sort of was the main outcome using our multivariate regression modeling to create these 3 categories for risk stratification purposes, and we identify these most important patient characteristics. And this is just some basic statistics here. We're not going to get into details, but basically, you want to look at ROC, area under the curve, to make sure that, look at the quality of your model. And AUC was 0.7606, which is pretty good. It's has more than acceptable accuracy. That's what sort of the model is telling us. And then part B is basically a calibration plot of our multivariate variable risk prediction model, which basically, says that the fit of our model on the calibration plot was, fairly stable, looking at each of the decile at all levels of risk. So that's essentially what it tells you. So we, feel pretty good about this. As Luca already referred to, looking at, we had a primary outcome, and then there were several secondary outcomes of interest. And one was to characterize predictive values of individual capnography parameters, such as end-tidal CO2, pulse oximetry, O2 reading, and respiratory rate. And we also used the Integrated Pulmonary Index algorithm, which IPI, which has already been previously defined. And on the bottom, I listed a reference to the paper, which was basically generated using several parameters for monitoring. And it basically what these authors did a couple of years ago, they integrated end-tidal CO2 respiratory rate, pulse oximetry reading, and heart rate. And then, again, looking at respiratory depression episodes, and they created a grading scale between 1 and 10. So this wasn't one of the other variables that we looked at. And what we did basically is to compare patients who with and without a respiratory depression episode, and looking specifically at incidence of adverse events, and hospital resource utilization, very important, within 30-day readmission, for example, and length of hospital stay. So all the very important endpoints that we wanted to look at potentially associated with respiratory depression. We also looked at predictive value of continuing monitoring parameters. And what we found is the most common were capnoGraphY and pulse oximetry alarms for apnea, low respiratory rate, and low end-tidal CO2. We didn't see any high end-tidal CO2 cases. Looking at IPI less than 5, which, as you go lower, it's worse. Apnea had the highest sensitivity. And then we looked at low pulse oximeter reading combined with low end-tidal CO2 reading had the highest specificity in detecting respiratory depression episodes. And as I already alluded to, some of the secondary outcomes of interest were adverse events on healthcare utilization. And interestingly, we found that 313 patients experienced at least one adverse event, which included 22 ORAIDs, opioid-related adverse drug events, in 18 patients. And I'll show you a table in a second just to summarize all of this. 10 of these ORAIDs were detected by capnoGraphY and pulse oximetry monitoring. 11 occurred in the absence of continuous monitoring, so those were excluded from our model derivation. And of patients who did have an ORAID, looking at the scoring system, 9, 6, and 3 were high, intermediate, and low risk of the Prodigy score, according to our calculation. And this is a nice summary where we basically summarize on the left-hand side, we summarize a type of adverse event, AE, hypoxia, respiratory failure, bradycardia, hypertension. Again, these things happen during their hospitalization, during the whole course of whether it was a surgical patient or medical patient. And you can see that on the bottom in that square, basically high-risk patients, 9, 6, and 3, and we identified a total of 22 adverse events in 18 patients. So of the patients with at least one respiratory depression episode, so in the study there were 655 patients, and then we looked basically at relative risk. So we found that patients who experienced at least one episode, and there were quite a few patients in the study who did, the relative risk was almost 1.4 for this adverse event requiring prolonged hospitalization, 2.5% almost risk for requiring rescue, as was discussed previously, based on a lot of literature that's out there, including rapid response team activation, versus patients who did not have a respiratory event. Readmission, we didn't find any difference, specifically patients with and without a respiratory depression event. But the mean hospital length of stay was actually 3 days longer in patients who experienced at least one event. And you can imagine cost implications of something like this. So in conclusion, respiratory depression events are common based on our study and the evidence that's out there. Current monitoring standards may not detect these events. Respiratory depression events don't necessarily mean clinical respiratory depression events, and we can discuss this in more detail, so a lot of it is a matter of definition and so on. And repetitive exposure to respiratory depression episodes may contribute to significant morbidity, as illustrated in our study. Prodigy risk score, as we introduced it today, it's easy to implement as a tool to predict these episodes. As I highlighted, patients, rated as high risk, at least looking at that high risk population, may benefit from proactive bedside interventions and need for a continuous cardiorespiratory monitoring. Thank you.